Ladies and gentlemen, it is indeed a delight to gather here today in the Pisik village of Transmara, where we have the distinguished honor of welcoming renowned pediatric consultant, Dr. Imbusi, who will graciously enlighten us on the intricate aspects of the pathophysiology of tuberculosis in children. Esteemed attendees and viewers, we extend our warmest greetings to each and every one of you as we stand here eagerly waiting the enlightening discourse that our esteemed speaker is about to embark upon. It is with immense pleasure and gratitude that we have the privilege to listen and learn from distinguished authority in the field. In the realm of pediatric medicine, tuberculosis is a subject matter of great significance, necessitating a thorough understanding of its multifaceted pathophysiology. Today, we are truly fortunate to have the opportunity to delve into this intricate topic with an expert who possesses wealth of knowledge and experience. As we commence this educational journey, let us express our sincere appreciation to our esteemed speaker, whose presence here is nothing short of an honor to each and every one of us. Karibu sana, Dr. Imbusi.
Good morning again. So, my name is Dr. Imbusi. So, I work at Mara County Referral Hospital. And I know when I'm saying my expectation is to make friends or make new friends, people are like, you know. But I realize I know a very small percentage of people here. So my desire was for us to collaborate more. You could be at a facility as a clinician, a clinical officer, or maybe you are alone as a nurse and you have a difficult case. It's always easy to reach out. Yeah, we may not have pediatricians in all the facilities, but if we do networking, then it's easier. You have a difficult case, you can always reach out and call and ask for consultation. So never feel alone or never feel that pediatricians too in CRH. So it's easier for you to call and we can always discuss the case and then mgonjwa afaidike, si ndivyo? So we'll go straight to pathogenesis. So pathogenesis is, I don't want you to crack your mind so much because we learned this in school, si ndivyo? It may be many years ago or a few years ago, but basically what we want to is to have a background of the pathogenesis so that we are able to know why it is essential to actually screen our patients and then offer them early treatment before they deteriorate. Because once they deteriorate, then even if you're treating them, you'll have poor outcomes. So we're looking at TB in children. As Barbo has told us, it's very peculiar. Problems with diagnosis, problems with getting the sputum sample, and then even when you get the sputum sample, some of them may not really give you a positive result. And so we want to look at why is that so. As we all know, TB is airborne, right? It's caused by Mycobacterium tuberculosis. Yeah, which is an anaerobic bacteria, and then it spread from one person to another. When a person speaks, when a person coughs, when a person sneezes, so more like COVID, right? Yeah, and you remember when we were looking at the trends, you realized during the time we had COVID, what happened? There was less TB. Maybe one, because people were wearing masks. True or false? True. The other reason could be maybe patients were afraid to go to the hospital when they have symptoms because they'll feel like they'll be told we have COVID, which was like a death sentence. Not so. Yeah, so either notification was very low because most patients were afraid of going to the hospital because when they are told they have COVID, first of all, mentally they're just so, they're psychologically they're tortured, and some of them were dying of high blood pressure even before the COVID kills them. So that's why we had that low notification. But then at the same time, because of hand washing, because of using masks, in public places, somehow the transmission of TB also reduced. So we have pulmonary TB and we have extrapulmonary TB, right? Yeah, extrapulmonary TB affects which places, which parts of the body? Yes? Hey, people have not taken breakfast. Yes? All parts of the body. Then there's an exception. No, we are cancelling this class. Lungs. I heard somebody say lungs. Except lungs. It's a cancelled class. Except nails. Okay. What else? Hair and then teeth. Good. So that is very correct. So we have extrapulmonary TB that can affect every other part of the body except the hair, the nails, and the teeth. So children are usually infected by adolescents and adults. So usually when we have children who have TB, they did not get that TB from other children. Okay, they could get it from older children. That's why the adolescents have been put there. But mainly the infection is from adults who are around them or within the community. So younger children rarely contribute to disease transmission due to the possibacillary disease and the reduced tuberculosis force. So, about the possibacillary disease, it just basically means they have a very low bacillary load, very low load of mycobacterium. So even if you're going to collect that sample, that sputum sample that in the first place it was hard to get, you may, even if you take it for testing, you may not be able to get a positive result. Because for children, a very small load of Mycobacterium tuberculosis can actually cause disease. Sawa. So for them, they do not usually have like a high bacillary load as adults. Adults usually get cavitatory disease. So in the cavity that is formed in the lungs, there is a lot of mycobacterium, even ranging to millions. Sawa. So for adults, it's easier. When they cough or when they expectorate the sputum, then you are more likely to get a positive gene extract result. But for children, especially the younger ones, it's less likely to get a positive result. So that is what we mean by possibacillary disease. That the disease they get is with a very small load of the bacilli. So when you do a test, most likely to be negative. Yeah, so a negative test does not negate the fact that there could be TB in a child. Then the other thing is about the reduced tuberculosis force. So they lack muscular strength. So even if when they cough, they're not able to actually expectorate a lot of the aerosols that will contain the bacilli to infect another person, as opposed to an adult. When we cough, we are able to expectorate a lot, a lot of aerosols, a lot of sputum. So usually the contamination and the transmission to others is very easy. Yeah. Then older children, that means adolescents or those above 10 years, have a smear positive and or cavitatory TB. Hence, they are as infectious as adults. That is self-explanatory, right? Yeah, that adolescents or older children basically have similar TB pathogenesis like that of adults. Sawa. Yeah, so they are infectious. So if an adolescent has TB, it's more likely going to be infectious as opposed to a 1-year-old child who has TB. So the presentation of TB in children is an indicator of recent and ongoing transmission of TB in the community. If say we have community A and community B, Transmara South and Transmara West, and then we have variable TB presentation like in children. Maybe let's say the incidence is lower in Transmara South as opposed to Transmara West. Then what basically means is where there is a higher incidence, in the higher incidence of TB in children, in that community, it basically means that there is ongoing TB transmission because they are basically getting the TB from the community. So pediatric TB trends, tell us more about the TB transmission in the community. Okay, so we go to more of now the pathogenesis actually. So the first box there shows exposure, right? There must be an exposure for one to actually get TB. For transmission to occur, we require exposure, right? Yeah, exposure is to a person who has TB or chronic cough, maybe not yet diagnosed with TB, but actually could be having TB. So from exposure to the primary infection, how long does it take? 3 to
12 weeks.
3 to 12 weeks. Those are 3 weeks to less than a month to 3 months. That is just from exposure to the primary infection. So, and at the point of primary infection, what is positive? Tuberculin skin test. So tuberculin skin test, or even IGRA, because they have the same mechanism of action, is very key in diagnosing TB early, before you even have the disease. So at this point where you see infection or primary complex, basically means infection has occurred, but we do not yet have disease. Still more of latent TB. Yeah? So it will take 3 to 12 weeks, but then even with infection, the primary infection occurring, what happens is we have a smaller percentage of those who are exposed and got the infection, yeah, who will actually progress to get the primary TB disease. So that is so, but look at the duration from infection, from the primary infection to the active disease. It takes 1 to 12 months. Okay, so supposing a child called Mary was exposed, say the grandmother had TB, so was exposed, and then it took 3 months. We're using the higher margin. It took 3 months to get the infection. Think of those are 12 weeks. Then it took another 12 months for the manifestations to actually, the TB manifestations to be seen. So what's the duration between exposure and active disease? 3 months, then 12 months. 15 months. It's 15 months, yeah? Isn't it quite a long duration? Yeah. Can it explain the reason why at times when we start doing contact tracing, or when we want to trace maybe the contact, it's usually very tricky? If it was a patient who was already maybe on TB treatment, yeah, or maybe it was a relative who had visited the family, the parents may not even recall. Or maybe it was at school, we do not know the source of the exposure, but usually what we mean is the duration at times can be quite long. So if a child is coming with signs and symptoms of TB right now, it may not mean that the infection, the exposure, and the primary infection occurred there and then. No, it may have occurred a while back. So, then the other thing to note is that the 5% who develop active disease usually mostly have impairment in the immunity. There should be an element of immune dysfunction. So what happens is, you'll notice that those who have severe acute malnutrition, they're very young, yeah? Or those who have any other form of immunosuppression, they will actually do what? They will actually easily progress to the disease. So they will belong to the 5%. Anyone with any immunocompromisation. So if a child is on steroids, steroids usually suppress the immunity. So say a child with nephrotic syndrome, then is a child who may easily get TB upon exposure. a child with severe acute malnutrition, a child with HIV, sasawa, and the very young, less than 0 to 4 years. Okay, let's go back to the luckier ones, the 95% who do not actually get the active disease. Their immune system is strong enough to do what? To contain the infection. So yes, the mycobacterium is there, but then the body's immune system has been able to mount a strong enough response to protect the body against the effects of the mycobacterium. So those are the 95%. So this 95% here, unfortunately, we have a 5% who later on, years later, can develop active disease, which is called reactivation disease or post-primary disease. Okay? But this is years later. So we have a subgroup of patients, and this is more common in the adolescents. We have a subgroup of patients who, when they're coming now with the TB or the signs and symptoms of TB, it basically just means that they may not have actually gotten the exposure within few years, like within the 1 year that we had put there. They may have gotten an exposure 5 years ago, and then their immunity at that time was strong enough to contain the infection. Then something happens and their immunity goes down. Maybe say they have a significant viral infection, or they have another debilitating illness that lowers their immunity. Then what happens? They have a reactivation disease. That is years later. So we can see here that the risk of progression to primary disease and the development of disseminated TB is increased in the very young, 0 to 4 years. Then also the immunocompromised, and then the malnourished children. So majority of children develop the disease within 2 years following exposure and infection. So I don't know how many of us have been lucky to get, when we start tracing maybe where the exposure may have come from. Anytime we have patients like children who have TB, were we able to get? Anyone who was lucky to get when you do screening, family screening? Anyone? I know we've managed TB patients. So it's common everywhere, because I think at NCRH, most of the time when you do screening for the family, we've never been lucky to get anyone that is positive. So, but this can be explained. If it takes 2 years, then it may not be easy to get infection, because we don't know if either the person maybe who was the exposure is not there at that time. Now when the child is presenting with the symptoms, so it's a tricky one. But it's good that we still continue screening. So transient hilar adenopathy occurs in the majority of patients who have a recent pulmonary infection. So we'll see that again in the subsequent slides. I hope you're following me. I don't want to leave anyone behind. This is a study that was done. If you can see, the topic was age-specific risk to develop tuberculosis following a primary Mycobacterium tuberculosis infection. It's a study that was done by Morois et al. It was done in 2004. It was published in a journal in India. And basically what was happening in this study is they wanted to assess the age-specific risk. Like what age on its own is a risk factor for developing TB, excluding the other factors like immunocompromisation. Yeah? So what happened in this study, they eliminated, the eligibility criteria was all children who had, within the given ages, but who were immunocompetent. So if there was any child who was immunocompromised, that child was excluded from the study. So all these, all the children who were involved in this study were immunocompetent, and then they were categorized in the different ages. We have the less than 2 years, we have 2 to 10 years, we have the greater than 10 years. Again, that age category is very, very key, because the less than 2 years, we said, their immunity is low, single. Yeah, they are more prone to getting TB than any other age group. Then the above 10 years, again, we say they develop which type of disease? The adult type, single, with cavitation. They are more infectious, and that means also they will get TB as an adult because they have a high bacillary load. So basically, that's why they categorize less than 2 years, 2 to 10 years, and above 10 years. And so when we look at the results, that is the risk of TB in immunocompetent children, we have 3 categories: those who never developed the disease, those who developed pulmonary disease, and then those who developed TB, meningitis, or miliary disease. And that was given for the different age categories. So we start with the less than 2 years. How many of them, upon exposure, did not develop TB? Wow. 50 to 70%. Then those who develop pulmonary disease, 10 to 30%. And then TB, meningitis, or miliary disease, 2 to 10%. It was 2 to 10%. Yeah, that is for the less than 2 years. Then 2 to 10 years, no disease, the percentage has gone higher. Yeah, so the percentage has gone higher because there were, remember, even the exposure was almost the same. All factors were constant. They are all immunocompetent and they were all exposed to patients who had TB. So, but remember, now when you go to the age category of 2 to 10 years, those who do not develop the disease, are quite, the number is quite high. So 95 to 98%, that's very high, Yeah, then when you go to pulmonary disease, the percentage has gone down to 2 to 5%, as opposed to 10 to 30%. Then TB, meningitis, or miliary disease, that means severe forms of TB, 0.5%, 0.5%, less than actually, less than 0.5%. Okay, we go to the above 10 years, who have a similar presentation like that of adults. So no disease has gone down slightly to 80 to 90%. Then pulmonary disease, 10 to 20%. And then TB, meningitis, or miliary disease, almost the same as that of the category of 2 to 10 years. Okay, so what can we say about these variations with regards to the age, the different age categories? So we think that age has an influence on the risk of developing TB. So the very young have a higher risk of getting pulmonary disease. So look at pulmonary disease. Pulmonary disease in less than 2 years, 10 to 30%. In 2 to 10 years, 2 to 5%. In greater than 10 years, it has gone 10 to 20%. So the highest is in less than 2 years. So the risk of developing pulmonary disease is pulmonary TB is actually higher in the less than 2 years. Okay, then the other thing is the risk of developing severe forms of TB. So miliary TB, which is also disseminated TB, as well as TB meningitis, there are severe forms of TB associated with a very high mortality and morbidity rate. Yeah. So what do you see with regards to TB meningitis? It's highest in which age category? It's highest in? Yeah, less than 2 years. So the less than 2 years have a higher risk. Yeah, so that's basically what it shows. So children contacts less than 2 years have a higher risk of developing TB than all the other age groups. So it means we need to be more aggressive in the diagnosis, yeah, and treatment, or else we will actually get the severe forms of TB and then we get poor outcomes. Okay, so we are looking at the progression of TB in children. And it's in patients, and I don't want the faces to confuse you. The reason why we're going through the faces is just so that you can basically understand that we have a phase that a child can be in and yet not have respiratory symptoms in the presence of TB. That's how, like this first phase. This is the first phase. So what happens is, because it's airborne, you inhale aerosols containing the bacilli, and then what happens, they go through the airway, the trachea, the bronchioles. Then, in response to that, or the bacilli is transported now through the lymphatic system to the nearby lymph nodes. Yeah? And also the lymph nodes could enlarge just because of as a response to because the body knows how to sense when there is a foreign body visible. Yeah, so the body's response could also affect the enlargement of the lymph nodes. So what happens in this first phase, remember, it's 3 to 8 weeks after primary infection. So what happens is granuloma forms in the lung periphery. So this is the granuloma. Yeah? That's the granuloma, red in color. It forms in the lung periphery because what happens, see, it's gone through the bronchioles, from the bronchioles to the alveoli. So from the alveoli now, what happens, the granuloma will form in the periphery of the lung. Then, in this phase, the only thing you have is the enlargement of the lymph nodes. And if you do a chest X-ray, you may be able to see a gone focus. So after the granuloma form, what happens next is that now the changes in the granuloma to form a gone, what is called a gone focus. So this is the gone focus here, the white or creamy white in color. Yeah. So in this phase, the presentation is very non-specific. You do not have respiratory symptoms at this phase. Okay? So no respiratory symptoms, no cough, no wheezing, no anything. So what happens is the only thing, as we said, the body is trying to mount up a response against the bacilli. So you can have a form of hypersensitivity reaction. So TB is more, the reaction that is mounted by the body is cell-mediated. Yeah, cell-mediated ilikuanga na kuna B lymphocytes, kuna T lymphocytes. Hizo hatutaenda into that. But basically what happens is, now you have symptoms like fever, erythema nodosum, you have positive tuberculin test or IGRA, and you have a formation of the primary complex on the chest X-ray. But remember, it's not easy to do a chest X-ray on a child who has no symptoms of cough. Hey, at least akwambie kuna cough. If there is no cough, usually we may not likely request for a chest X-ray. So meaning we will never see a gone focus. True or false? True. We may not see it on the chest X-ray because by the time we are requesting for chest X-ray, the child has symptoms of cough and respiratory distress and all that. So in this phase, remember, in the first phase, if you don't remember anything else, remember what? You have non-specific symptoms. So low-grade fever, poor weight gain, and lethargy. Okay? Non-specific symptoms. And also, the tuberculin skin test to be positive. So you remember at the point of the primary infection, we said that the tuberculin skin test to be positive because it shows latent TB. So in this phase, tuberculin skin test will also be positive. So most of the time, this phase is missed out. So we go to the other phase. That is phase 2. And in this phase, this is now the phase where you have respiratory symptoms. So what is happening up there, as the lymph nodes continue to enlarge, they do what? They compress the airways. Sindio? The right, this is the right, the left bronchi, and the right, one of the bronchioles on the right side is affected. So you find that there is narrowing. So what happens is, this is a child who may come with wheezing, yeah, because of narrowing of the airway or compression of the airway by the enlargement of the hilar lymph nodes. So they'll present with wheezing, and mostly what we do when patients come with wheezing, we nebulize them. Yeah. So please, if you have a child who has the other non-specific symptoms, poor weight gain, lethargy, loss of appetite, and low-grade fevers or high-grade fevers, who has wheezing and responsive to salbutamol, to nebulization with salbutamol, remember to consider TB. The other thing with wheezing in TB is that it is most likely going to be unilateral. So when you're scaltating, you'll feel the wheezing is more on one side than on the other side. So, because rarely we do have compression. In few circumstances, we do have compression of both sides, because that means that patient will have significant severe respiratory distress. So the other thing that is happening here now, we say that the bacilli can, through lymphatic spread, the bacilli goes to the lymph nodes. Now through hematogenous or whatever lymphatic spread, it can also spread to other parts of the body. But here, what happens here is that they spread to the lung parenchyma. You can see here, this is the lower segment, this is the mid segment on the right side of the lung that is affected. Apart from the lymph node enlargement, what we are seeing here is the lung parenchyma is involved. So we have a form of bronchopneumonia. But also here on this other one, we have only one segment involved, which is lobar pneumonia. So in this case, the spread of the bacilli was more to one side of the lung. So this is what now we have a form of pneumonia. Yeah, that is TB pneumonia. So this phase takes 1 to 3 months after the primary infection. Then you have bronchial spread to the parenchymal lung, that is TB pneumonia. You can also have parenchymal lesions spreading to the pleura. So if they spread beyond the lung parenchyma to the pleura, then we have pleural effusion. Then it is at this phase that you have spread to other parts of the body, whereby now you can start getting extrapulmonary TB. Because once it has gone to the lung parenchyma, of course the bacilli is able to access the capillaries and the blood vessels, so there will be hematogenous spread now to other parts of the body. And because also of the lymphatic spread, you can have it spreading to other parts of the body. So you can have, commonly in the younger ones, it's meningitis and miliary TB, but you can also have other forms of extrapulmonary TB. So respiratory symptoms, yeah, including wheezing, may be present. You can also have a persistent non-remitting cough or wheeze that is unresponsive to treatment, yeah, for likely alternative cause, like the common asthma that usually, get commonly. Then the presentation includes advanced symptoms like weight loss, poor appetite. At this point now we have high-grade fevers, fast breathing, poor feeding, lethargy, and basically this is an unwell child. Sawa? Yeah. So the other symptoms will depend on where the bacilli has spread to. So if it is meningitis, and then you can have the symptoms for meningitis. If they have maybe say spinal TB or let's say miliary TB, then you will also have the classical signs for the same. So this is the stage that we most likely get our patients, or the phase wherein we get our patients. Usually by the time the mother is bringing the child to the hospital, it is at this phase. Wakati mtoto ako na low grade fever, just lethargy, poor feeding, so they usually go to a nearby chemist, they get paracetamol, they get multivitamin, they try to treat symptoms. So by the time now the child is, there is no improvement, the mother is telling you, appetite hatakuwa nayo kwa muda mrefu, lakini nilikuwa nadhania ni nini, mama sijui nilikuwa nadhania ni nini. They usually have explanation as to why. So usually the challenge is we get the patients at this stage whereby the spread is, it's more likely for them to have hematogenous and lymphatic spread to other parts of the body. So we have a very narrow window to treat them early enough. So remember, MAN2 test will still be positive in almost 70% of these patients. That last diagram shows miliary TB. Miliary TB is the easiest to diagnose. Even if you're waking up from sleep and you're given a chest X-ray and everything, all through the chest X-ray, you're seeing small millet seeds. You know, small minis, opacities like millet seeds. Miliary TB. Yeah, it's usually classical, very easy to diagnose, but the problem is usually also miliary TB is also called disseminated TB because it's not just the pulmonary involvement. Usually they have involvement to other areas, and if they are less than like 2 years, the most common other involvement is, area of involvement is the brain. So usually most of them who have miliary TB, please make sure you rule out TB meningitis if they are very young. So these are the other phases. We have phase 3. Phase 3 occurs 3 to 7 months after the primary infection. So in this period, for those who are above 5 years, they can actually get pleural effusion, and those less than 5 years, they get bronchial disease. So in the very younger ones, it's less likely to get pleural effusion. Any case scenario, we are told diseases don't read books. They just decide this is how we're going to present, regardless of what Nelson says or what any other pediatric text says. Have we had any child less than 5 years with pleural effusion? The one I've personally seen, 2 actually, were 5 and 7 years. Yeah? So pleural effusions are more common in those aged above 5 years. Okay. Then phase 4 basically is 1 to 3 years after the primary infection, whereby, remember our gone focus that we have seen? In this case, the gone focus is up here. So what happens is that when this gone focus undergoes calcification, you can, when it undergoes calcification, it can, what happens, you can actually have, it calcifies, but then later on it can be, you can have reactivation because the bacilli is just still inside there. So it's a period of osteoarticular TB in children aged under 5 years, and we have reduced risk of disease progression. During the bone focus calcification, there is no progression of the disease. Then other type of disease that is in adolescents with delayed clinical onset may occur after calcification. So what happens during the calcification stage, there is no progression, but a few months to years later, then you can have now the progression. So the last phase, more than 3 years later, and this is basically what we are saying there, reactivation disease. Yeah, reactivation disease. So let's always remember that our children are at a higher risk of developing TB. They are at a very high risk of developing TB upon exposure. So that we have agreed upon. Yes. Yeah. The other thing is, even if the exposure was with a very low bacillary load, they can actually get disease. because of their low immunity. So again, even after eliminating all the other causes of low immunity, their age just puts them at that place of them having a low immunity. So age is an issue that works against them. The other thing is that when we take our samples to the lab to test and do gene expert, they may be negative because of the possibacillary nature of the disease. And the fact that they are also not able to expectorate, we get challenges with specimen collection. But good news is, again, we'll be told that now we can use tools to do gene expert. That's good news, isn't it? Good news. Yeah. So I think that is it on the pathogenesis. I hope your brains are not, you're not tracking your brains too much. Even it's treat it like look at the most important and the confusion. Confusion. You can always refer to the notes. You can be given the notes, so kitaka to refer in your own free time, you can always refer. So I don't know if we have questions about the pathogenesis. Any clarification, any comment or question?
Wow! I express immense gratitude to the esteemed Dr. Imbusi for diligently enlightening us on the intricacies of the pathogenesis of tuberculosis. To all viewers and attendees, I humbly implore you to graciously consider subscribing to my esteemed channel, Etnandi Empress, to partake in an unbroken journey of unceasing knowledge acquisition and personal development on tuberculosis. Thank you, and remember to watch the next video, and be blessed.